Good day, everyone. My name is Dr. Richard Brown, and I work for WHO Thailand. Today, I will be providing a presentation that gives an overview on infectious disease prevention and control in Southeast Asia. So what this presentation will cover is something about infectious diseases in the region. Then I'll talk about some infection prevention and control, or as we refer to it, IPC concepts and terminology. Then something about different modes of transmission of infectious diseases and their implications. I will say something about WHO guidance and strategies on IPC, including the built environment. A few thoughts on natural ventilation and green hospitals, and then how COVID is providing us with some opportunities. So, for infectious diseases in the region, I mean, there are many, but you can really classify them into endemic diseases, which are here all the time. And I'm using the example of tuberculosis, otherwise known as TB. Then we have to consider epidemic diseases, the ones that are more unstable, but have the potential to cause large outbreaks or even sometimes pandemics. But also to mention something about the scale and impact of AMR, or antimicrobial resistance. So TB is sometimes thought of as a disease that was very prevalent in the past, but it does have a significant burden in the Southeast Asia region of WHO. And you can see that this map shows the countries in Southeast Asia, and it's color-coded according to some figures which are believed to reflect a high incidence rate, a medium incidence rate, and a low incidence rate. And you'll see there are some countries that are more impacted than others. And this chart is showing how the levels of TB in Thailand have fluctuated over the years. So the blue line shows the estimated number of cases, whereas the red reflects the number of cases registered for treatment. So the first obvious thing to say is that there is a difference. So there are cases of TB out there, we think, which are not being kind of captured by the medical healthcare delivery system. But also what you might notice is that this graph goes up to 2022. And unfortunately, the number of cases registered for treatment have dropped off recently. And this is believed to be at least partly due to an effect of COVID. So we've got a bit of catching up to do. I might say before we move on that TB is transmitted by the respiratory route, and it's actually transmitted by aerosols rather than droplets, which is quite unusual. And I'll be explaining that terminology a little bit later. But then, of course, we've just been living through COVID, which had a significant impact. But this slide is giving some information about how severe the influenza pandemic was in 1918. So these cases, when people became unwell, presented really most of the time with what we regard as classic flu symptoms. So with sore throat, runny nose, fever, aches and pains, and sometimes cough. But it was much more severe. About 10 to 20% of cases would develop pneumonia, and the case for fatality proportion was 2.5%. So between 2 and 3 people of every 100 that got infected died. And this is actually much higher than we saw with COVID. But some of the descriptions you see are really, I think, to me, quite scary. So these next few bullets are taken from a letter that was written by a doctor who was working at a camp at the end of World War I, where people soldiers were being held prior to going home. And he describes this so-called purple death that occurred not infrequently within 24 hours. And he says things like they rapidly develop the most vicious type of pneumonia ever seen, that cyanosis, which is this blue discoloration of skin, which is a result of you having very little oxygen in your blood, spreading so quickly that it was difficult to distinguish color people from white, and about how they needed special trains to take away the dead. So really quite scary stuff. And I think, you know, I and other people are still really concerned about influenza, the potential for an influenza pandemic that could be worse than what we saw with COVID. Then moving on to antimicrobial or antibiotic resistance. I'm not going to go through this slide. It's quite busy. But just really, if you look at the graphic on the left, what I highlight is that there's really, you know, according to one study that was done, a very big problem in Thailand. You know, according to this estimate, the number of deaths per year in Thailand were actually greater than the United States. And then in the graphic on the right-hand side, it was estimating that deaths attributable to AMR in 2050 could be as high as 10 million, which is a bigger impact than is predicted for any of these other diseases you can see, including cancer. And similarly, there have been some projections done by this guy, O'Neill. And again, I'm not going to go through it. You can have these slides, but it's really to show that according to the graphic on the right-hand side, the biggest burden of AMR is predicted to be in Asia. So in the countries where we are living and where many of us are from. And I guess one obvious thing to me, which I haven't explicitly mentioned, is that AMR is very much linked to the problem of infectious diseases, and it's also very much linked to infection prevention control measures in hospitals, because one of the biggest concerns is the transmission of infectious diseases in hospitals, including due to bugs that are resistant to antibiotics. So the two topics are really very much linked. Similarly, just to drive the message home again, the economic impact of health emergencies can be really considerable. And for example, one estimate of the impact of SARS suggested in 2003 it was 30 billion, but I think undoubtedly COVID was higher. So moving on to infection in healthcare facilities and IPC, the sources of infection in the patient or the individual who has the infection, who might be at risk transmitting it to others, are all known. So people can have infection in their body fluids, in blood, saliva, sputum, nasal discharges, wound drainage, urine, and in excrement or feces. Infectious sources also include objects that are contaminated with any of these things I've mentioned. So contaminated surfaces are a problem, but so are used tissues or any other objects that have come in contact with secretions. And normally these are objects that are located within 1 meter of the patient. And that's going to say something about what we refer to as standard infection prevention control precautions. So basic IPC precautions apply whenever anyone is providing patient care to anyone, whatever the diagnosis is. So what really underlies this is that we make an assumption for every single person that is admitted to a hospital that they could be infectious. And whilst you might expect someone who has an infection will have symptoms, that is not the case. For example, there are bloodborne infections which, if you like, are latent. They are not obvious. You cannot tell by looking at someone or measuring their temperature or even doing routine blood tests. You can't tell that they're infected. So we think it's important that there are some basic precautions that are applied universally to everyone. And as the second bullet said, the idea is to prevent unprotected contact with body fluids, blood, secretions, and excretions. And in doing so, we minimize the spread of infection to healthcare workers, to other patients, but also to other staff who work in the hospital, including porters, including people who work in administration, and also to family members. I'm sure for some of you, it's quite common in your countries that members of the family will stay in hospital with a patient. And the main elements of standard IPC precautions are important in the context of this talk, because these are things that need to be thought about and taken into account in the way a hospital is arranged, including its design, but also the layout and the access to some of these measures. So one of the most important things is hand hygiene. Very easy to do, but very easy also to forget to do. But the implication is that people need to have access to what they need to be able to wash their hands. Meaning either a faucet that supplies water with soap, or to some kind of alcohol-based hand rub. Then the next thing is it's important to use some kind of personal protective equipment to avoid contact with the patient's body fluids and on intact skin. And probably the most simple example of this is just wearing surgical gloves. Then it's also important that everyone understands and practices respiratory hygiene and cough etiquette. You probably all know about coughing into your elbow, but also it's about disposing of tissues that have respiratory secretions in a safe way. It also covers prevention of injury from needles and other sharp objects. Importantly, sometimes forgotten, is linen and waste management. Anything that might be contaminated with infectious secretions, you need to take care of. But it also includes cleaning and disinfecting the environment, but also not just respiratory equipment, but also things like surgical instruments. And I'm next going to talk about some IPC precautions that are specific to respiratory infections. And I will make a distinction between what we call droplet precautions, which are applied to respiratory infections that are spread by droplets, and aerosol precautions, or sometimes referred to as airborne precautions, which need to be applied through diseases that are spread through the air. And these are not the same. So droplet precautions, as I said, are to prevent the transmission of pathogens that are spread via droplets. Droplets are transmitted by an infected person when talking, coughing, or sneezing. But these droplets, although they are very small, they are heavy enough that they typically fall to the ground within 1 meter, certainly within 2 meters. But this means they can land on your skin, your nose, your mouth, or the eyes of unprotected people, or they can land on a surface. And sometimes these infectious secretions can stay infective for some time. But these droplets do not stay suspended in the air. Then droplet precautions require the use of a standard medical or surgical mask when within 1 meter from the patient. And you apply these precautions whenever providing care to a patient who is suspected or confirmed of having disease spread by droplets. And these medical masks, as I'm sure you've seen, the shapes can vary quite a lot, but they do not always create a very good seal to your mouth. And the pores, the holes in the mask are not as small as they are with the so-called N95 masks, which I'll mention next. So airborne precautions are practiced to prevent the transmission of pathogens that spread through so-called droplet nuclei. So the infective particles are much smaller and they can stay suspended in the air. And therefore, these pathogens can remain infectious over a long distance in excess of 1 meter. They can stay floating in the air and remain infectious. there are actually not that many infectious diseases that are spread by this route, but TB, as I mentioned, is one of them. Also measles and chickenpox, but very few other are airborne. Having said that, there are circumstances under which other infections, including influenza and coronavirus, can become airborne. And I'm sure you remember there was a long and sometimes quite difficult to follow debate about whether or not COVID was really transmitted by the airborne route. But the other important aspect of this is when a new, never before seen respiratory disease first appears, we always have to consider the potential for airborne transmission. And I think this also applies to almost anybody who is admitted to a hospital with a respiratory disease where you do not have a diagnosis. So it's for these diseases spread in this way through aerosols, so-called airborne diseases, where it's really important that you keep a patient in a well-ventilated area and separate it from other patients. So what we do whenever possible is place this kind of person, this kind of patient, in an airborne precaution room. And there is guidance about the number of air changes per hour, as you'll see. It's also to think carefully about the flow of air. So you have to assume that if you have a patient that's infected, you can have him placed in a room that's being ventilated, but anything downwind of the patient is potentially going to be at risk of infection. And what we often do is that the air just gets vented outside when it becomes diluted very quickly. There are other things you can do, including the use of filters. And you can also get quite good information about airflow just simply by checking with a tissue paper. It'll show you the direction of airflow, but it'll give you some kind of indication about how strong the airflow is. Also, for this type of infection, it's really important that you use a particulate respirator, or otherwise an N95 mask, whenever entering a high-risk area. And there is just one more aspect of this that I want to mention, which is that it's quite common in hot countries to use air conditioners. But this is problematic because air conditioners work by recirculating air until it goes cold. And really, you don't want to, for a patient who has this kind of infection, encourage that kind of airflow. But if you decide to deal with this by venting air outside, it means that you're always venting cold air. So the air conditioner has to run a much higher rate to try and keep the room cold. So it's very common, in my experience, in countries in this region, hot countries, to think that the best thing you can do is have someone in a room where an air conditioner is running. But it's very, very expensive. And you'll be hearing about the principles of natural ventilation. I will mention it a little bit. But this is just one of the reasons where we think if the conditions are suitable for using natural ventilation, using intelligent building design, incorporating these principles of knowing where is the prevailing wind and exploiting differences in temperature, then it just has these kind of advantages, because obviously an airflow from a natural source will also have a cooling effect on your skin. So what I'm going to do with this slide is just also to try and get across some basic concepts about modes of transmission. And I think probably the most important thing for you to remember is that there are only there are limited ways that infections can be transmitted. We know what they are, and we know how to interrupt transmission in every case. So infections can be transmitted by contact. We've talked about contamination of environmental surfaces. But contact can also be from person to person. What is the design implication? you need to have a building that has ready access to hand washing facilities, but you also need to clean. And so it's about maybe thinking about how you can facilitate the design of a facility so that cleaning becomes as easy as possible. Infections can be transmitted through food and water. Probably the biggest problem globally is through this so-called fecal-oral spread. What does this mean? It's all about having good arrangements for sanitation and hygiene, which is toilets, but again, it's about hand washing. Then bloodborne infections are important, but I don't think they really have design implications. If as I mentioned, in a hospital, everyone should be applying these standard precautions. It's important to avoid needle stick injuries, and I guess you need to have the equipment to be able to take blood safely at any point of care, but I don't think it has big design implications. Sexual transmission, I don't think it has design implications. It's important. Maybe we should make sure that there are condom machines, at least in the toilets of healthcare facilities. Vector-borne diseases can be important in tropical countries, particularly, in Thailand, there's a big problem with dengue, also with some other diseases like one called chikungunya. And I think this does have implications for design. And one of the difficulties about applying these principles of natural ventilation is it does cause a problem with ready ingress of insects, particularly mosquitoes. And this can you can mitigate this to a certain extent by the use of screens, but screens will interrupt the flow of air. I mean, air will still flow through a mosquito screen, but it will slow it down. But one thing you can do is to try and make sure you at very least limit the opportunities for mosquitoes to breed. So it's about making sure there are no mosquito breeding sites, no areas where there are standing water all around your healthcare facility. Then I've mentioned respiratory droplets. This is about routine distancing. Also, one of the things I mentioned is that in some situations, even diseases like influenza can become airborne. And this is when you conduct so-called aerosol generating procedures. And I don't really have time to go into this, but the what's important is that for certain medical procedures, including intubation for someone who needs to be ventilated, but also undertaking resuscitation for someone who's got a life-threatening disease, it should be done in a room where you have very, very good ventilation, even for respiratory diseases that normally transmitted by droplets, but particularly for aerosols, these diseases where infectious particles remain airborne. It's critically important that you have good ventilation, not just ventilation, but the ventilation is very important. But it's also important to emphasize that infectious diseases can be transmitted by more than one route. And I've mentioned already that very few infectious diseases are actually spread by aerosols. So I just wanted to say something about WHO guidelines, and I'm not going to go into the detail, but it's really just to say that as a reference for you, if you do have the time and interest, there are guidelines on the so-called core components of IPC programs, both at the national level and at the acute facility level. And if you look at the detail, there are 8 core components, 6 at facility levels, but just 6 at national level. They contain 11 evidence-based recommendations and 3 good practice statements. But and it's based on the best possible evidence that's available. But I also highlight that component 8 is about the built environment, materials and equipment. So these guidelines do say something about healthcare facility design and the arrangements of healthcare facilities to facilitate good IPC measures. And this is saying the same thing, but in a more kind of visually appealing way, to emphasize that that the built environment, materials and equipment, along with workload, staffing and bed occupancy, are all important part of an enabling environment. And then there are other things that IPC programs need to have, including guidelines, education, training, surveillance, monitoring and audit. So you really need all these things to come together to have the best practice in a healthcare facility. This is some of the detail about what it says about the built environment, materials and equipment. And I've highlighted in red the things that are maybe important for you. So an appropriate environment includes water, sanitation, hygiene, services and materials and equipment. Also, the second bullet is actually really important because providing or ensuring these arrangements is the responsibility of senior facility managers and local authorities. There's a limit to how much nurses and doctors can do when it comes to the design of a hospital. It's really important that we, engage the right people upstream. And I guess this applies more than anything to the design of a hospital. Right at the beginning, when maybe a design is being conceptualized, the people who are making the decisions need to understand and seriously think about applying these concepts. Also, as I've mentioned, there needs to be a hand hygiene product, easily accessible, as close as possible, i.e., if possible, within arm's reach of wherever patient care or treatment is taking place. So point of care products should be accessible without having to leave the patient zone. And one obvious reason for this is if you need to wash your hands, you may be infected. And the last thing you should do is then walk across a hospital ward past other people, past other patients, just so you can wash your hands and go back again. And there is guidance about the minimum sink to bed ratio. It should be at least between 1 to 10, but ideally 1 to 1 in isolation rooms. Just some other design considerations for IPC. I know one of the lectures is covering triage, but the point is that it doesn't just apply to mass casualty disasters. We set up triage during COVID and during the previous influenza pandemic as a way of finding people who might have a respiratory infection as early as possible. Because when someone arrives at a hospital, you don't know what the diagnosis is. And maybe, as I've said, you assume everyone may be infectious. Everyone might have a respiratory disease. But if you can separate these people and ensure that they follow a separate pathway through the hospital, it's a way of minimizing the risk of transmission. So it's not just about triage. It's about thinking, what is the patient pathway from the time they arrive at the hospital to where they need to go to be assessed and have their investigations, including maybe X-ray, and then about how they go to a hospital ward. And the implication is that you need easy access to hand washing for everyone, everywhere. And a couple of important things is that when people are putting on personal protective equipment, but particularly when they're taking it off, there may be some infection risk, and it's a good idea to have a separate space where staff can do this. So you might sometimes see in an isolation unit, there is an anteroom where a healthcare worker will go to put on and take off their PPE. But particularly when you're taking off PPE that may be infectious, it emphasizes the need to have safe arrangements for waste disposal, which you have to assume may be infectious. And then just a couple of thoughts on natural ventilation. I mean, I'm a big fan of natural ventilation, but I think it's important also to flag that there may be collateral benefits. So just generally, fresh air is good for you. And you may have heard of this so-called sick building syndrome, which seems to be, it's partly about having access to green areas and to natural light. But I think part of the problem is just about rebreathing stale air. If you have natural ventilation, it should not be a problem. But as I mentioned as well, wind has a cooling effect. And especially if the inflow of air into a building is over water, it can have an even greater cooling effect. And I mentioned already the problem with using air conditioners. But I think also linked to this, there is potentially what I'd refer to as a green hospital dividend. I think if we use a combination of natural ventilation, but also together with things like solar power and wind power, we can think about clever solutions that will work in almost any situation. So one of the problems with natural ventilation is obviously what you do when the wind isn't blowing. And that's where this concept of hybrid systems come in. So when the conditions are favorable, you use natural ventilation. When the conditions are not favorable, you need to switch over to some kind of mechanical ventilation. But often, you can store energy when the sun's shining. When the sun's not shining, often the wind is blowing. So I think, using intelligent building design with green energy sources, it should be possible to provide solutions that are more sustainable in the long run. And as I mentioned in my talk about flooding, it also increases self-reliance of our healthcare facility in almost any kind of disaster. So again, I've mentioned some of these already, but what are the problems with natural ventilation? So I think one is that, in my experience, senior policy makers just seem to think that having negative pressure systems and air conditioning is better than natural ventilation. It's kind of more modern. You probably do need to have these hybrid systems to cover when the wind isn't blowing or there's no temperature differential. But it is, I think, a little bit challenging to think about how you easily switch between these modes. Is it something that can be automated to happen very quickly, or does it have to be switched over manually? It is also hard to avoid the ingress of insects, which may include vectors of transmission, but maybe smart design can significantly reduce breeding sites or eliminate these vectors, including mosquitoes, in other ways. I think if we are talking about potentially venting infected air to the outside, where we think it will be diluted, and this is an alternative to using filtration systems, which again will be a problem in maintaining airflow. We may need to convince decision makers that it is really safe. Is there a risk to someone who's outside their healthcare facility downwind that they might get infected? And I'm not sure that there is a lot of good information about this. And lastly, one intrinsic problem is that it is more difficult to achieve natural ventilation with larger buildings, which is just a function of the surface area to volume ratio. And then lastly, I won't go into this, but I think for those of us working in public health, we do see COVID as an opportunity. So at the moment, there is still quite a lot of attention on the need to build back better. There's funding available. And, there's an attempt by WHO and partners to think about what we do in a much more holistic way. So there are opportunities, I think, to introduce these ideas and concepts now, so that we can, apply, solutions to the prevention and control of endemic and epidemic infectious diseases in a much more comprehensive and granular way. Then maybe just lastly is to just say briefly that there is now a global strategy on IPC. So the first ever global report on IPC, maybe surprisingly, was only published in 2020. And then there has been a lot of work that's been done since then. But this year, just a few months ago, there was this global a strategy on IPC adopted. And again, this is an opportunity. And you may say, so what? But the thing about having a strategy like this adopted at the World Health Assembly is partly that countries then are expected to report back on action they've taken to implement the strategy. And, 2 years down the line from now, if countries are reporting back, it's quite embarrassing then if they have to say that they haven't done anything. So sometimes, getting a strategy like this adopted at a global level is an important lever for change. And so in this context, I just wanted to mention that there are components that are highly relevant to this discussion in this global strategy. So I've highlighted in yellow. One is that it's important to have steps to ensure that sustainable IPC, water, sanitation, and hygiene infrastructures and resources are in place. Then it's also important to recognise the value of having IPC professionals across a variety of settings with appropriate competence, skills, career pathways, and empowerment. And then lastly, to create and implement accredited infection prevention control curricula within pre-graduate, postgraduate, and in-service continuous education. I think this is in all disciplines where it's appropriate, which is why this initiative is also important. So also CC, the component core capacity 8 is about environment, equipment and infrastructure. The next ones are all about education and training in IPC. So thank you for your time. I hope you found this useful. I think there will be an opportunity for you to ask me questions and I'll do my best to answer them. But until then, thanks for your time.